that his asymmetry improved a lot. However, residual asymmetry remain. He still have mild lip cant, chin deviation. Also, contour at both sides are unequal. This situation usually happen in asymmetry patient. So, what is the reason of this residual asymmetry? After surgery, residual asymmetry can be separated into skeletal and soft tissue part. Skeletal residual asymmetry include position, size, and shape asymmetry. Soft tissue residual asymmetry can also include size and shape asymmetry. If we want to improve the surgical outcome, skeletal positional asymmetry should always be corrected before size and shape asymmetry. So in this study, we focus on skeletal residual positional asymmetry. So our question is, what is the influencing factors of asymmetric class 3 corrected by orthodontic surgery with residual asymmetry? Before doing the study, we searched for the database, include PubMed, Midline, Web of Science, and Base for relevant English language literature up to March 2022. And we found that there are 14 studies related to lip cant. And the factors related to lip cant include maxillary cant, molar cant, and menton deviation. And for the jaw deviation, 2 studies were found to be related to jaw deviation. And the factors related to jaw deviation include maxillary cant, mandibular cant, and menton deviation. And for the dental midline, there are also 2 studies related to the dental midline. And we found that the factors related to upper dental midline asymmetry include maxillary yaw asymmetry. Factors related to lower dental midline asymmetry include mandibular yaw asymmetry. And last, for nose deviation, there are 2 studies. And the factors found to be related to nasal deviation include maxillary cant and mandibular shift asymmetry. So here is the conclusion of the systematic review. There's no literature reported the influencing factors of residual asymmetry in post-op asymmetric skeletal class 3 patients. Also, there is no information about facial contour. Changes of lip cant were correlated with changes of menton deviation, maxillary occlusal cant, and mandibular canine cant. Changes of jaw deviation were correlated with changes of maxillary roll asymmetry and menton deviation. Changes of nose cant were correlated with changes of maxillary roll asymmetry. Changes of nasal midline deviation were correlated with changes of mandibular shift asymmetry. Pretreatment jaw deviation has been reported to be correlated with maxillary cant, mandibular cant, and occlusal cant. Pretreatment maxillary and molar midline deviation have been reported to be correlated with maxillary yaw asymmetry and mandibular yaw asymmetry, respectively. In the future, more statistic studies should be conducted to understand the post-op correlated of hard and soft tissue residual asymmetry, which will provide helpful information regarding the effects obtained by orthodontic surgery. So the purpose study are to evaluate the treatment outcome of bimaxillary surgery for class 3 asymmetry. Also to find the influence factors include initial severity, residual positional jaw asymmetry for residual soft tissue asymmetry. Material method, patient selection. The inclusion criteria of patients are Taiwanese adults who received 2 jaw surgery. They are all skeletal class 3 with significant facial asymmetry. And they all had 2 jaw OGS in our center. And exclusion criteria include major systemic disease, cleft or craniofacial syndromes, patient who had rhinoplasty or NS deviation, or history of craniofacial bony surgery will be included. This is the flow diagram of the study design. All patients received surgery first approach and had routine combing CT records pre-op and at least 1 year after surgery. 3D measurements of soft tissue were measured before and after debonding. Skeletal positional asymmetry was measured after debonding. The CBCT was taken in natural head position and centric occlusion and were reconstructed in Aviso software. All images are analyzed by a single investigator. The head were reorientated based on the landmarks of PNS patient and the clear side of orbital to define the mid-sagittal plane, horizontal plane, and coronal plane. We take endpoint as origin. Before analysis, all images are flipped over so midline are all deviated to left side. After head orientation of T0, in T1, 3D models were superimposed with T0 at anterior cranial base and forehead region. For soft tissue asymmetry outcome include 3 categories. Include soft tissue midline asymmetry, lip cant, and contour asymmetry. For soft tissue midline asymmetry, nose, upper lip, lower lip, mandible, and chin deviation were measured by transverse distance of 5 landmarks from the mid-sagittal plane. For lip cant, it was measured by the vertical distance difference between the left and right chalian. For the contour asymmetry, we divided contour asymmetry into 3 parts: upper, middle, and lower contour. Upper contour points are the points passing through lateral facial contour with the same horizontal levels as subnasal and labial superioris. Middle contour points are the stomian and labial inferioris. Lower contour points are soft tissue B points and pogonium point. And the contour asymmetry was the discrepancy of transverse distance between right and left facial contour points. The second part of the study is post-op positional asymmetry of skeleton, include maxilla, mandible, chin, and ramus. Shift, roll, yaw asymmetry will be calculated. For maxilla, mandible, and chin, central plane were constructed. If the plane overlap perfectly with the mid-sagittal plane in 3 dimensions, the plane reached perfect symmetry. If perfect symmetry are not achieved, there are residual asymmetry of the skeleton. Then shift, roll, and yaw asymmetry will be calculated. For positional asymmetry of maxilla, we define it as a plane that passing through ANS, PNS, and incisive foramen. The shift asymmetry of the maxilla were measured the distance between ANS and the mid-sagittal plane. The roll asymmetry was the rotation angle of maxillary central plane from the mid-sagittal plane around y-axis, assessed from the frontal view. And the yaw asymmetry was the rotation angle of maxillary central plane from the mid-sagittal plane around the z-axis, assessed from the frontal view. For the mandible central plane was defined as passing through the medial genial tubercle and bisecting line of the lower border of the mandible. The shift asymmetry was calculated of the distance of medial genial tubercle to the mid-sagittal plane. The roll asymmetry was the rotation angle from mid-sagittal plane around the y-axis, assessed from the frontal view. The yaw asymmetry was the rotation angle from mid-sagittal plane around the z-axis, assessed from the frontal view. For the chin plane, it was defined as the plane that passing through the menton and the line perpendicular to lateral chin point line. The shift asymmetry was measured from the menton to the mid-sagittal plane. The roll asymmetry was the rotation angle of chin line from the horizontal plane around y-axis. The yaw asymmetry was the rotation angle of chin line from the coronal plane around the z-axis. Last was the ramus. For ramus, triangle plane of the bilateral ramus were constructed. If right and left ramus plane overlap perfectly after right ramus plane mirror to the left side, the plane reach perfect symmetry. If perfect symmetry are not achieved, there are residual asymmetry of the skeleton. Then shift, roll, and yaw asymmetry will be calculated. The ramus plane, we define it as passing through the sigmoid point, anterior ramus point, and posterior ramus point. The shift asymmetry, we measure the discrepancy in transverse stiff turn from the mid-sagittal plane between the sigmoid point left and the sigmoid point right. The roll asymmetry, we measure the discrepancy in roll angles from the mid-sagittal plane on both sides. And for the yaw asymmetry, we measure the discrepancy in yaw angle from the mid-sagittal plane. To reduce the method error, 10 randomly selected CBCT measurements were repeated by the same investigator in at least 2 weeks interval. Intra-examiner reliability was analyzed by the intra-class correlation coefficient. The reliability was excellent. For statistical analysis, using pair t-test to see difference in asymmetry outcome before and after surgery. Stepwise multiple linear regression to see the related factors for post-op asymmetry, such as initial severity of soft tissue asymmetry, post-op positional asymmetry of skeleton. The significance level was 0.01. Here's the result. 65 subjects are included, 32 female and 33 male. The average age before treatment were 25-year-old. The average NB angle minus 3.2. The severity of mental deviation was 6.5 millimeter. 10 patients received maxillary segmentation. 45 patients received genioplasty. Here is the residual skeletal asymmetry of maxilla, mandible, chin, and ramus. We can see the degree of asymmetry was most severe in ramus row, and the rest are equal or less than 2 degrees or 2 millimeter. And for the soft tissue and dental midline asymmetry, most of the variables have significant improved, except nasal midline and upper contour asymmetry and upper dental midline. And the result of the regression analysis, the x-axis is the residual soft tissue asymmetry, y-axis is the related vectors. For the midline asymmetry, half of them are related to initial severity, and it always related to its underlying jaw shift asymmetry. And for Lipkin, it was related to maxillary roll and initial severity. And for contour asymmetry, it was related to its initial severity and ramus shift or roll asymmetry. And for dental midline, upper dental midline was related to maxillary shift, roll, and mandibular shift and yaw asymmetry. Lower dental midline was related to mandibular shift and yaw asymmetry. Discussion. First, our study used new analysis method called central plane and triangle plane. The benefit of our methods are simple and accurate in terms of using skeletal landmark to construct the plane. And the landmark won't be affected by osteotomy cut or bone remodeling. Also, the planes are related to the osteotomy segment and can give you the severity of positional asymmetry, include shift, roll, and yaw asymmetry. For the residual soft tissue asymmetry, the extent was highest in chin midline deviation in the contour region. And we can see that the extent of contour asymmetry increased toward lower part of the face. For residual chin deviation, in the study by Suzuki Okumura, chin deviation was related to mandibular roll asymmetry and hard tissue chin shift asymmetry. In our study, however, chin deviation was only related to hard tissue chin shift asymmetry rather than mandibular roll asymmetry. The possible reason was in their study, they exclude the case with genioplasty, and they use correlation analysis. But in our study, 69% of patients had genioplasty, and we use stepwise regression analysis. For residual lip can, in our study, we found that residual lip can was related to initial severity and maxillary roll asymmetry. This result is the same in Suzuki Okumura study, but in the study by Jung 2017, lip can was related to mental deviation. The possible reason might be because in Jung's study, they do one jaw surgery. And in their study, they use correlation analysis, and we use stepwise regression analysis. For the residual contour asymmetry, we found that initial severity of contour asymmetry, roll and shift asymmetry of ramus were significant factors of postoperative contour asymmetry. The residual lower contour asymmetry was affected by the ramus rather than the underlying mandibular body. And for the residual upper dental midline deviation, Song study, they analyzed pretreatment variables and found that maxillary yaw asymmetry was the primary contributing factor for upper dental midline deviation in patients with upper dental midline deviation greater than 2 millimeters. However, in our study, the residual upper dental midline is related to maxillary shift and asymmetry and mandibular shift and yaw asymmetry. The discordant findings may be due to that in some they exclude samples with medication more than 4 millimeters preoperative to minimize the effect of mandibular asymmetry on maxillary deviation, and they did not evaluate the effect of variables related to mandible. In another study by Ryu et al., they also analyzed pretreatment variables and found that upper dental midline deviation was not significantly correlated with mandibular roll or yaw asymmetry, which is different from our result. And the lower dental midline deviation was significantly correlated with mandibular yaw asymmetry, which is similar to our result. The possible reason for the discordant finding for upper dental midline deviation may be due to the different variable for positional jaw asymmetry. In their study, they measure by the line, and we measure by plane. And also, they measure the pre-op. They measure in pre-op, and we measure the residual asymmetry. For the nasal midline deviation, in Suzuki Okumura study, they found that the change of nasal midline was related to the change of maxillary roll. However, in our study, it was related to mandibular shift and yaw asymmetry. The difference may be small sample size in Suzuki Okumura study, which they only measure in 9 patients. And in John Ewon study, they found the same result as us. They also found that the mandibular shift was the main factor of post-op nasal midline deviation. And the reason of this result is that maybe because that we usually need to sacrifice the nasal midline in order to achieve favorable overall facial asymmetry, especially in the mandible. So here is the conclusion. Bimaxillary surgery for class 3 asymmetry can have significant improvement in midline asymmetry, lip can and contour asymmetry. The major influencing factor for residual asymmetry, for midline asymmetry was jaw shift asymmetry. For lip can, it was related to initial severity and maxillary roll asymmetry. For contour asymmetry, related to initial severity, ramus roll or shift asymmetry. Thank you for your attention.
I would like to invite questions from the audience. Do you have any questions to Dr. Wang? I would like to ask Dr. Wang a question. The mid-central plane is very important for your research because it is the baseline for you to compare the deviations. So how do you define the mid-sagittal plane in this study?
In our study, our mid-sagittal plane is the plane that passing through three points include posterior nasal spine, and deviation. The reason that we didn't choose nation and N as deviation is that we found that we can usually find the N as sometimes we can find the N as deviation in facial asymmetry patient. But posterior nasal PNS was usually no obvious asymmetry, so we choose NPNS and deviation as the mid-sagittal plane.
How about the cases if the you have mentioned that for cases with some residual asymmetry, they may involve with some of the maxillary roll and the shift rotations. So if the maxillary has been shifted, usually the PNS will be changed. So the midline will not stay in the same way. So also some of the patients, they have head orientation. So how do you correct these variables and factors in individuals, patients?
I think we said the mid-sagittal plane before the treatment. So after we just superimpose the T1 T1 to T0. So there is no influence of the change of the mid-sagittal plane after patient had the surgery. 我们是用 T0 做 head orientation， 然后所有的 T1 全部 superimpose by the cranial, not affected by the surgery.
谢谢 advisor 廖医师。那个所以as we learn from Dr. Wang's study that row asymmetry is really important, especially maxillary row. And I would like to ask surgeon how to improve the row accuracy during the surgery, because for the vertical part in the posterior plane, sometimes it's hard to precisely catch, even with we had intermediate stent. Any surgeon want to comment on this part? Surgeon. Dr. Low or Dr. Zhou, would you like to comment on this part?
我看是没有 surgeon 在 respond， 因为我是晚进来的，很抱歉，所以我没有 I did not hear the previous presentation. So, but if your question is how to control the row rotation during the operation, am I right?
Yes, yes.
Well, if I use the two spring, double spring, so the first intermediate spring will address the everything. So just use the intermediate spring to control the row rotation. Of course, if I do maxillary first, then the first intermediate spring should control the maxillary position and the row rotation, right? And if I do the mandibular first, then the maxillary row rotation will be decided during the second, the final spring. That will be easier to perform the when we execute the operation. Certainly, we still observe, even we use the double spring to control the two jaw position, we still observe the occlusal plane.
Mm-hmm.
But I think that if we use two spin, double spin procedure, basically the position of the two jaw is controlled by the individual spring when we do the fixation. So during the surgery, I just further observe if this final position is correct before I do the fixation.
Yeah, I think Dr. Low's intermediate steps then has a extra mechanism to accurately detect the row because there is an extension in the front. So I think that's a very smart way to improve the accuracy of row, since that it seems the row rotation is a significant factor to affect the residual asymmetry. And also there is a factor called chin deviation and symmetry related to the residual asymmetry. And we know that the chin contour sometimes is related to the size, shape, not really the position, although we can identify the midpoint of chin, but actually the chin contour sometimes has deviation. And as Dr. Wang studied that the yaw and the roll of the chin sometimes is difficult to control, right? As your study has mentioned about that. So I think that for the genioplasty in face asymmetry is really a touch at the final that we can do some side shifting, roll and yaw to improve the contour asymmetry. However, we don't regularly have a way to transfer the image simulation to real surgery. Sometimes is justified by surgeons. So I think in the future, for cases really need a very delicate chin surgery, maybe we also need an extra guide to guide this genioplasty. Yeah.
Can I respond to the genioplasty?
Yes. Yes.
I think the genioplasty is very important in terms of the final outcome, because if you have a beautiful chin, that the whole face look more, more complete, more perfect. For example, even you have the 4-1 BSSO in the right position, but if the chin is not looking good, then as a surgeon, when I look at my patient, I feel that, oh, I didn't do a good job if the chin was not looking good. And from the literature, still some surgeons design the chin and even do the and even do the positioning guide, whatever, or prevent plate in the genioplasty and fixation. And when I do the 3D simulation, I also simulate the chin position, but basically that's a simple simulation of the chin. But I believe that surgeon should be responsible for the final chin, whether with or without genioplasty. And if I do genioplasty, what kind of genioplasty I would like to do? Shortening, lengthening, shifting, narrowing. There are many kinds of chin operation that we can perform. So to me as a surgeon, I really that's that matters from the experience and also your intraoperative judgment. Difficult to use the 3D simulation to decide the final chin. So I think surgeons should be responsible. That's my personal opinion and also experience. But I would really like to emphasize the chin, the final outcome in terms of the facial appearance.
Thank you, Dr. Law.
Professor Cole.
Yes.
This is Daniel Huang. Could I ask
Yes, Dr.
one
Huang.
questions?
No problem. Yeah.
This new classification is much better than the older one used by National Taiwan University now. But I still have one question, because in the chart, you have shift, low and yaw. What's shift? Means displacement in 3 dimensions or displacement in which dimension?
For
Dr.
shift,
Wang explain.
for shift asymmetry, like the maxilla, we measure the distance between N and S to mid-sagittal plane. And for the mandible is the distance between medial genial tubercle to the mid-sagittal plane. So it's in
Which distance? You didn't say it really clear in the diagram.
oh
Or the shift.
the in the x-axis. The
Okay,
distance.
made clear. And
Okay.
then my second question is, and all the numbers you present are really small. It's less than 1 degree. Or the other diagram, most of the time after the surgery is about 1 something, but 1 or 2 degrees is not clinical significance. So I don't know. You have a statistic significance before and after the surgery, is that right? For this
Yes, most of the variable.
Yeah. So even for the chin, 2 millimeter, it's still clinical acceptable
Yes.
after the surgery. So you got to add this kind of tolerance for clinical overall outcome. Yeah, although you can express it as accurate as possible. Thank you. For the contour, for the soft tissue, that's another problem too. Usually still remain large. even after the surgery. Any comment on that?
For the contour asymmetry, we can see it still remain more than 2 millimeter. Is still quite obvious after the surgery. And
You got to have pilot study for the contour unsymmetric. What kind of measurement any person can perceive the unsymmetric for your assessment. Most of the person may not perceive contour symmetric as accurate as a midline unsymmetric. So try to do some pilot study for the contour unsymmetric. Otherwise, all the number greater than 2 millimeters should be reoperated.
oh,
Don't do that. Thanks a lot.
thank you.
Thanks, Dr. Huang's comment. And Dr. Wang, that you have done a great job on this study, and you put a lot of efforts. So do you want to say something that has been through when you do this study? What have you encountered some difficulty, and what can be improved if you do it again?
I can do it again. I think in my study, for the most difficult part is to define the central plane of maxilla and the mandible. Maybe because I don't have enough experience in really make sure the central plane is in the middle of the whole maxilla and the whole mandible. And for this part, Dr. Liao helped me to check all of the case to make sure that the central the point is really, after I place the three of the point, it is really in the center of the maxilla and the mandible. I think it's the most difficult part of my study. And maybe in the future, we can cooperate with some engineer to help us to define the central plane automatically by some system that can make it more accurate, instead of count on the need to count on the experienced doctor to help to define the central plane.
Thank you. And Dr. Liao, you are the advisor. Do you want to comment on that?
I have tried to ask Jaguar to write a program, but he said the program has to be written by the French engineer, and it will cost a lot. So I was turned down by Jaguar. maybe in future we have enough money to do this job. I think it's very important to make it semi-automatic or automatically to improve the validity and the reliability.
I remember I read an article that from Xia Zhong, Dr. James Xia, and he developed a program that can automatically define the mid-central plane, and I think that's a pretty smart way. But I think it needs some engineer to help us to do that. Yeah. any other questions from the audience? And OK， 还没有什么问题。好，这个月大概我用中文讲哈，这个月大家提醒一下，因为9月份有一些就去年科技部没有过的，那今年可以再投一些个人型的计划。那整合型的计划，好像9月15的构想书，如果各组要投到15以前，构想书要出来啊。然后大家也要注意一下，就是自己那个 IRB 那个时数有没有够这样子。那个美君有没有什么问题？哎，我要谢谢那个王医师今天的那个报告哈，非常的detail， 而且非常的仔细哈，非常看起来是花了很多的功夫。那谢谢。那不知道梅君有没有什么要跟大家补充一下的？
就是柯医师刚才有讲了，就是如果要投明年的那个科技部的那个整合型计划的话，那9月15之前要先把构想书给我，因为我要给林口医院到。
好像没有听到。等一下 OK， 好。那如果没有问题的话，我们今天的meeting 到这里结束。那敬祝大家中秋节快乐。好，好，哎，事故，好，事故。
喂，就是9月15之前要把那个整合型的构想书给我，因为林口医院部他这次想要请顾问先帮大家看过构想书的内容，因为他想要提高那个计划的通过率，所以他才提早这么早的时间收集大家的构想书。所以各组如果想要投明年的科技部的整合型计划的话，就麻烦要9月15之前把构想书给我这样子。那当然就是也是像柯医师说的，就是要大家注意一下自己 IRB 的时数，要记得上去上课这样子。对，谢谢。
好，谢谢梅君。那世谷有没有什么要跟大家说的？
没有，这边没有。
没有哈。
对。
好，那就今天 meeting 到这里哦，大家就各忙各的。那祝大家中秋节快乐啊！谢谢。